All, welcome to one more show. This is Dr. Mobeen Sayed and Dr. Luffy sitting next to me. Let's start a discussion with a camera on Luffy. So give me 1 second and get ready for camera being really bad because I'm going to switch to the webcam. So here is Luffy sitting next to me. And since the morning, he has been hanging out here with me. And here is a chair actually for him to sit on, but he's found a better place to be here on the table. So here, Luffy and I, and hopefully Barbara and Lotus and many other are with their cats as well. So let's start a discussion. Just wanted to show you that Luffy is here as well. Okay, so the discussion today, there were so many questions that were on YouTube, as you saw, and there are so many questions that are on Twitter. Just one day's request that, hey, give me your questions. So I thought today, let me try to answer all the questions on the YouTube side, and then we'll take another day to answer all the questions on the Twitter side as well. So at least we move forward. There are folks who are waiting on these questions. So having said that, let's start our discussion. I'm going to share my screen and we'll go from there. So this is drbeen.com. I wanted to start from here. I think that many of you know about this, that there is a retraction of the paper by Dr. Periodically and by Dr. Paul Marek. This paper was here in Sage Journals. And I saw Dr. Z was talking about him in the comments as well. I called Dr. Periodically. I called Dr. Paul Marek today as well. I asked them how are they doing and what's happening, if they need anything, if we can be of any assistance. I asked Dr. Paul Marek kind of more candidly. I said, is the data really incorrect? And he said, no, it is not incorrect. However, my situation is such that the administration is strong-arming this whole situation. So I asked him, I said, what can we do? And I can understand that nowadays I am under a lot of pressure and attacks. And there is actually, anyways. So I asked him, I said, what can we do? How can we assist? And he said, tell Cool Beans about this all. So then I requested him, I said, why don't you join us one day and we discuss this? So he said, I would love to. So we will soon have Dr. Paul Marek with us, and we will have a discussion about what is going on, why is he stopped from administering the medicines that he think are appropriate for his patients. And then he has now filed a lawsuit as well. Here is the retraction as well. If you look at the retraction, it is really not Dr. Marek or Corey retracting it is actually the hospital sending the note to this journal to say this paper that uses the numbers for our hospitals is using the numbers incorrectly. So this is a very strange time. And so let's continue. I want to make sure that we can add a lot of value to today's talk. There is a lot of data to be looked at, and there are a lot of questions to be answered. So let's start them. And I hope everybody is doing fine. I'm going to just scroll up to the questions. Today, we'll try to answer all the questions on the YouTube side. Then we'll take up the Twitter side a little later. And once again, just before we start, let me show you Luffy once more. He's still sitting there, and he's sitting and sleeping. He's sitting and sleeping. Luffy, how are you? You doing good? You doing good? Okay. So here's my friend. All right, back here. Let's start. So there's a lot of information to be discussed. So get ready and let's go on a roll. So we'll start from here. Casey says, does ivermectin affect half-life of other cytochrome P450 digested medicines such as flecainide and warfarin? So the short answer is yes. We know that ivermectin induces P450 and other liver enzymes as well. And when it would induce them, it would change the metabolism of other drugs. So what I did was, for your help here. One, I went to this study. This is a study, effect of ivermectin on activities of cytochrome P450 isoenzyme in mouflon. I think these are goats, sheep, and fallow deer. Dama dama. These are beautiful. Anyways, the basic point is, does it do something to the enzyme? The result indicate that ivermectin should be considered as an inducer of several cytochrome P450 isoenzymes, including a bunch of other enzymes, meaning in this category, the enzymes from the liver. The comparison of induction effect of ivermectin in rat, mouflon, and fallow deer also demonstrates the interspecies differences in inducibility. So there is a difference. That means in humans it would be different too. Then what I did was, for your service, I went to drugs.com and I checked the interaction. So you can go to drugs.com, and then on the top here it says interaction checker. You can go to interaction checker. Let me just do that right here. And you can type in the drug. So let's say ivermectin being one. And then you can add another drug. You could continue to add drugs. So let me say warfarin. Luffy is totally approving of all of this that is happening here. I don't think he's very happy about what is happening with the polymer. I talked with Pierre Corey as well. So interactions between your drugs. Warfarin, ivermectin applies to warfarin, ivermectin. If you see, there is a moderate interaction. Ivermectin can increase the effect of warfarin and cause you to bleed more easily. Call your doctor immediately if you have any unusual bleeding, bruising, vomiting, blood in your urine or stools, headache, dizziness, weakness, or taking these medicines. I hope you realize why they're saying this. Unusual bleeding, for example, from nose or ears or gums. Bruising, easy bruising on the skin. For example, sometimes just grabbing would cause bruising, or grabbing something can cause bleeding, vomiting, blood in your urine or stools, and so on. So there is an interaction. So short answer, yes. Then can you compare? So I had talked about this yesterday. This is a longer question. I'll leave this. John Snyder says, I like the old office, by the way. Thank you very much. And I know that this is not the best yet. As you see, it is actually not a very wide cupboard either. This was just sitting here in this room. I will continue to work on this. And I actually went to buy two 4 feet wide black cupboards, but they were I think $1,100-$1,200 each. So I just said, whatever, I'll work with this one. So I'll continue to improve this one. So then Bukhari AA says, are the different symptoms of COVID due to the characteristic of the virus or the host's immune response? Thank you. And so here is Luffy. So the Bukhari short answer, it is because of both. And so we know that in the beginning, when we have SARS-CoV-2 based infection, COVID-19, so Luffy just went to his chair. Sorry, running commentary for what Luffy is doing. When the SARS-CoV-2 attacks us or infects us and causes disease, the symptoms initially are because of the SARS-CoV-2's damage to the tissue, but as soon as the damage starts, immune system starts responding. So it is not that immune system would just sit around and say, let the damage occur. We have innate arm. Innate arm's job is immediate defense. Our skin is part of innate arm. It is always trying to block the viruses and bacteria and fungi and other things to enter our body. That is an immediate defense. Similarly, when the virus arrives, let's say in our mouth, we have saliva that is part of our innate system. It kind of traps the virus in there. There are enzymes in the saliva that might digest it. Then there are IgAs present that is part of the innate arm. It is by the adaptive arm, but it becomes part of the barrier. But it's not necessary that IgA is always present against every pathogen. Then we have macrophages, dendritic cells, neutrophils, NK cells. So all of those cells would immediately try to start responding to the virus, and they would also start creating cytokines, which would cause local inflammation, which would cause pain, swelling, redness of the tissue. And all of those, plus the tissue damage together, make up the symptoms. So that means it's not a matter of this or this. It is always a combination. The question only is severity could be because of viral damage. For example, let's say somebody's immune system is not competent enough, and it's just the virus that is wreaking havoc. Or maybe somebody's immune system is too reactive, too aggressive in reaction, and causes a cytokine storm. So that means I hope you realize, Bukhari, that it is always going to be a combination. It is possible one or the other may be dominant. Next question. Tech Roach says, one, what risks do exosome exhaled from recently transfected people pose to the non-transfected, ditto S1 subunit shedding in transfected people? So very quickly explaining this part, transfection and the exosomes. And Jody is here. Hello, Jody, back to you as well. Or overcompetent with mast cells. Yeah, absolutely, Denise. Sorry, I was just so busy looking at this here. So let's do this. I'm going to very quickly. So the question is, what risks do exosomes? So let me show exosomes as well. So here is a nice little article. What are exosomes exactly? And here is a good picture of that. This picture is of, and it must be copyrighted. So this is a copyrighted material. I hope that authors do not mind it too much. We are just educating ourselves. We'll just use it for a few seconds. If you see over here, this is an Epstein-Barr virus that is infecting a B cell. So this huge mass of gray is a B cell, and this B cell is infected by Epstein-Barr virus. And these little bodies that you are seeing here, these bodies are multivesicular bodies or vesicles, and I'm going to explain it. Then these vesicles from inside the cell can be removed and secreted outwards. These are here, and these are the exosomes. So let's very quickly now understand what these are. So here, let's say we have a cell, and in this cell, let's say SARS-CoV arrives. Right? So this is a SARS-CoV virus. When the SARS-CoV arrives, it would, you know that it would generate its mRNA, not generate, but it contains mRNA, which will then connect with the ribosome, which will then make spike proteins and the remaining parts of the virus. And then those virus parts will be assembled and then released. That is the normal assembly. Now, it is a theoretical concept in that study which talked about exosomes and the spike protein in exosomes. It is a theoretical concept. I'll continue to say they wrote, the authors, that they think it may happen, and they have not proven it. So having that as a conclusive fact and then building on top of it is actually wrong. So what they are saying is that it is possible that these spike proteins may be, or messenger RNA pieces, may be secreted outwards from the cell, trapped in these vesicles, and then they can be picked up by another cell, just like lipid nanoparticle, and they can go in that cell and then cause issues there. That's the basic theory, which I have been saying again and again. It's a far-fetched idea, but this is the idea they have. Now, to go to your question, let's go here. The question is, what risk do exosomes exhaled from recently transfected people pose to the non-transfected? So over here, there is a given fact that you are using, or there is an assumption that you're using as a fact, and that is that recently transfected, and I would take that as recently vaccinated. Transfected people pose to the non-transfected or not vaccinated, right? So number one, vaccinated people do not shed exosomes, or they do not shed spike proteins. And I have done this discussion before, so don't take my word for it. Let's just very quickly look at the mechanism, and then you can confirm this mechanism. And again, I want to make sure that here, when we discuss things, we are discussing things as doctors, as healthcare professionals, or people interested in medical concepts, not as talking head me, for example, for a position of vaccination or anti-vaccination. That is a disservice which we would do to ourselves if we try to put ourselves in various groups. So my request to everyone over here, I see sometimes comments and I become so disappointed that people just start going off the rails when they think that I'm not talking about something that they want me to talk about. This is medicine. I'm going to talk about vaccine side effects. I'm going to talk about the theories. I'm going to talk about the vaccine's benefit, and so is for the other drugs as well. So, without continuing on my soapbox, let's start our discussion here. This is the deltoid muscle. In this muscle, the vaccine is given. So, let's say there is some cell over here, some cell, let's say fibroblast. Fibroblasts are present almost everywhere. So here is a fibroblast. And this fibroblast, lipid nanoparticle enters this cell. And then the lipid nanoparticle contains the mRNA for spike only, and that spike mRNA is given out. Then this cell would start making spike proteins. Those proteins will be then shredded with the endosome, and majority of them will be crushed, broken down, and then they would be presented on the surface. Now, is this a possibility that spike protein might get out? There has been one study in which they said they found the spike protein to be stuck to the surface theoretically in computer simulation, not in actual physiological mechanism. They saw in computer simulation that if there is an RNA, this RNA that is in the lipid nanoparticle, if that RNA has a mutation in it, has a damage to it, then it is possible that the spike protein can become secreted and not stay attached to the cell membrane and get away from it like a balloon from a child's hand that slips away. And that spike protein, they said, could be running around. Now that is a in silico study, that is an in computer study. Is it really happening or not? If it was happening, we would be seeing it. Now, I also want to talk about the study which many doctors continue to say that the lipid nanoparticles go to other parts of the body and they cause damage over there. And a very common thing, which I think is part of fear mongering, is to just say lipid nanoparticle goes to ovary. And all of a sudden we become alerted because going to ovary mean damage to ovary and then a problem with the family and the whole uh, issue. And that's a serious thing. It's not an easy thing to work with or to expect. And I had done this discussion to the detriment of my mind, that from that day till today the attacks have not stopped. But this is a fact that that paper did not talk about lipid nanoparticles. That Japanese paper did not talk about lipid nanoparticles going to ovaries and other place. It said pieces of lipid nanoparticle, because the lipid nanoparticle itself, when it went into a cell, it broke down in there like an egg. So when it broke down and it released its messenger RNA in the cell, then pieces of the lipid nanoparticle, these were, they emerged from the cell. Some pieces, majority of the pieces were destroyed inside the cell, but some pieces released out. And you can say, why would they come out? Well, we're talking about a lipid nanoparticle. It's a lipid. A lipid can easily cross the cell membrane to go in or go out. Why do we have a lipid nanoparticle? Because the messenger RNA cannot get into the cell or out without help. Why is that the case? The reason for that, I think it's a simple thing, that we know the cell membrane is made up of two components. The two components are, or two types of components, I should say, not two components. One is the lipids, which are lipid bilayer, we call it. So let's say this is a cell, this is the cell membrane. So there is a lipid bilayer, and then on outer side and inner side, on the outside and inside, the lipids are attached to phosphates. So that's a very clever design. So phosphates are outside, PO4s, and lipid nanoparticles are in the, sorry, lipids are in the center. So water can be outside, water can be inside and interact with phosphates. Water interacts with the charged particles, but water cannot cross this that easily, although it can. Oh, it's water. But other particles that are charged, they cannot cross this because lipids are neutral and they would repel the charged components of anything to pass from it. That is why we have specialized channels, for example, sodium channels and potassium channels and calcium channels and magnesium channels, zinc channels, because these charged particles cannot just freely move. Now, RNA is a charged molecule. So if you put an RNA out here, this would not just move into the cell. Or if you put it in the cell, it would not just move out of the cell. A healthy cell would not allow that. So how do we send it in the cell? We wrap it into a more neutral molecule, which is lipids. Lipids like cholesterol and others, they, when you wrap this RNA around the lipid, then this lipid becomes a ship, a closed sphere, which can then cross through the cell membrane and go in. When it goes in and it breaks down and releases the mRNA, this mRNA cannot get out now. It's very simple and logical. If mRNA could move in or out by itself, then why do we need to wrap it in a lipid nanoparticle? So this mRNA, once it is removed from the lipid nanoparticle, it is trapped in there. Now the pieces of the lipid nanoparticle can then get out because these are lipids. So the end result of this is that lipid pieces could come out and they could go to any tissue and they get biodegraded in those tissues. They do not cause inflammation because our body is used to working with lipids, and these lipids that they have decided were of the sort that our bodies are used to. There were two lipids in there. There were four kind of lipids used in the lipid nanoparticle. There were two that we are already used to, cholesterol and one more, and polyethylene glycol, or surfactant 2 actually. And then there were two that were new. So they were interested in finding out what are these new lipid pieces, what are they going to do, who's going to break them down, liver or muscle or so on. So going back to the original question that we have here from TechRoach, and that is, will we be shedding the spike proteins or exosomes? So the answer is no, because once we have this cell which has gotten the lipid nanoparticle in it, messenger RNA comes out of that, not of the cell, but then we make the spike proteins. The spike proteins are shredded, presented. This cell is mostly going to be killed by the immune system and so on. This cell may release some pieces. This is may release. This cell here in the deltoid may release something which is an exosome, which may have a spike protein in it. Very interesting. It is never seen. But I'm trying to support your point of view to say, okay, let's release a spike protein out wrapped in this ship of an exosome. Even then, for this little thing to now go from the deltoid all the way to the throat, then be secreted out into the saliva, and then to be shed out is impossible. From a mechanism point of view, again, I'm not favoring a vaccine or not favoring a vaccine. It's just from a mechanism point of view, this is not going to happen. So the answer to your question, can this happen? This has been a question that was talked in terms of shedding as well. That can vaccinated people shed and make unvaccinated people more sick or sick? So the answer is no. So due to S1 subunit shedding in transfected people. So I have done this discussion before as well. S1 subunit shedding would require a similar thing, that somehow the vaccine has to produce the spike here, spike has to break down, S1 has to be released, then that S1 has to be shed, and then whole thing has to happen, which is not going to happen. One more thing, and this is why the folks who keep using these Again, TechRoach, you asked a question, so I'm not criticizing you at all. I'm actually appreciative that you asked it. I'm talking about the folks who use this. Look, here is a spike protein, correct? You know that spike protein, the S1 and S2 unit, will only become separated once the S1 is near an ACE2 and there is TMPRSS2 here. So let's say this is the TMPRSS2. This is not the best TMPRSS2 legs. Okay, let's make the legs like this. And it has this little scissor and it can cut the S1 from S2, correct? So this S1 that would be cut would only be cut when it is attached to the ACE2 enzyme. So if you look at my hands for a second, the spike protein, first it has to be released from the cell. Then it has to come and attach to the ACE2. Then the TMPRSS2 that is standing near has to cut it, prime it. Then the S2 subunit has to separate. Now the thing is, this S1 subunit will not just separate away because it is attached to the ACE2. They both, in theory, will become pulled in when a receptor is used. There are multiple kinds of receptors, but receptor and ligand interaction are of many types as well, many types too. Some types, it is a receptor, some ligand comes and attaches here, causes the conformational change, causes a secondary signal to appear inside the cell does something, and this guy outside would just go away. And now another molecule can come and attach here. This is a possibility. Then there are also receptors where when a substrate or ligand attaches, then they both get internalized and we have to recycle these. So here, I think what I know is, and I may be wrong, but what I know is that once the S1 and S2 are connected, they are pulled in, they are downregulated. So there was a study that said downregulation. That means S1 is not free now to go about getting shed. So one, it is not free, it is going to be downregulated, digested, destroyed, and removed. Secondly, how would we have this ACE2 bound S1 somehow separate from the cell and then go all the way and be shed? So good question, and hopefully it makes you comfortable that this would not happen. Let's answer a little bit here as well. M. Gregory says, is there such a thing as a good virus? So there are going to be many comments now that would say the viruses are made by God as well, so they're all good. I want to give you an example. It's all relative, correct? For example, there was a study a few days ago, which I discussed, which said that people who were infected by human coronavirus, who got that infection, common cold with human coronavirus, when they got infected by SARS-CoV-2, the symptoms of SARS-CoV-2 were lesser, milder, and they didn't even have a problem. So now this human coronavirus all of a sudden became a blessing for these people who became infected by it, had developed immune system which cross-reacted with the SARS-CoV-2 and protected them. Now, the same human coronavirus, let's say we take a different time when we are not talking about SARS-CoV-2, but the human coronavirus becomes active in somebody, it becomes so severe that it causes them to be bedridden or hospitalized. Normally, human coronaviruses don't do it, but it also depends upon the person's health. Now, the same virus is not a good virus for this person. So I think it is going to be relative that what virus we're talking about, what is the body's context. There are some pathogens that are helpful all the time for us. There are some pathogens that are all the time harmful for us, like SARS-CoV-2. And then some pathogens can be relatively helpful or harmful depending upon the context, as I just gave this example. But good question. More of a philosophical question. Okay, so Let's answer some more questions here. Colin says, is it not be a problem within silico studies as computers deal in logic in every scenario? Viruses are not logical in every scenario means it has to ignore immune system to pose certain scenarios. So the thing that we do in silico studies, these are good sophisticated computers that look at the possible. So you have to figure out the structures beforehand, and you have to tell as accurate structure as you can give to the computer. Then computer can simulate magnetism, for example, between the two bodies and say they would react or not react. So that much is good. Do you know that this was a big deal? It still is a big deal. If you take a rope, if you take a single thread of a protein, and if you drop it on your hand and let it coil up, how will it make that little mush over there? How will it curl into that ball? Predicting that through a computer is a huge deal. There is no program yet that can actually predict the tertiary structure of a protein or folding of a protein when it will be folded. And so lately, last year, there was a software that had come real close, and that was a big breakthrough. The reason for that is supporting your point over here. If a computer could, in a lot of good accuracy with precision, can fold a protein, that means you give the computer the messenger RNA or the genetic materials recipe, the genetic material structure, and computer can then build the protein from there and then decide how would it fold as well. This is like deciding. I'm going to give you an example for us that how difficult it is for the computer. Imagine somebody is pregnant and we are asked to predict how the face will look like. And so we all can have our own guesses. We would say it would look like mother or father or combination and so on. But these will be the guesses. Similarly, you have given the computer the recipe and said, tell us what structure in 3 dimension will it make. Computers cannot tell us that. But there are softwares that are coming very close. The more close they come to tertiary structure, the more easy it would be for them to tell the interaction, and the more this problem that you're saying will be resolved. So your point is correct, although we have a lot more advanced systems and they can do it with lots of accuracy. If you tell the structure by yourself to the computer, then computer can do the remaining interactions. It's not 100%. Why it is not 100%? There have been many computer simulations where various drugs were thought. So computer picked up a drug molecule, picked up SARS-CoV-2 and decided if they'll match or not. And computers have given thousands of drug molecules to say they should in theory match, but all those drugs do not work for SARS-CoV-2. Okay, so that's a very good question. All right, going back here for a few more questions. So that was, so John Doe says, could recovery from an infection limit risk from spike protein in a way that the COVID shot does not? Could recovery from an infection limit risk from spike protein in a way that COVID shot does not? So I don't understand the question very well, but I'm going to try to interpret it. And if my interpretation is wrong, then my answer is going to be wrong as well. So let's say I have become infected and then I become recovered. Now, my risk with the spike protein. So let's say I have an exposure in the future, and that exposure is going to create the spike proteins. Am I less at risk of the spike protein damage versus if I had a vaccine shot? If this is your question, then no. Spike protein, one, it does, the vaccine shot has side effects. However, that study of the spike protein it's a theoretical study. They created transfected cells. They kind of created, I'm going to use a negative term, they created Frankenstein cells to prove a point and said We think this can happen. We would love people to go do more studies and do more research. And I said in that talk as well, hopefully these researchers or some other folks would now take that and work more on it. Okay, continuing. One more question here and then I come to the Robin. I can see Robin here, and I can see Robin here as well. Wow, you're everywhere, huh? So Robin says, would love to see a discussion on the various IVM protocols. Yes, will do. I more involved discussion. We'll have to do it on Odyssey as well. It is so bad. I have still not tried Odyssey. Guys, if one day, tomorrow, day after, you don't see me on YouTube, go to community tab and see, maybe I have a link there for Odyssey. I may be on Odyssey. I have to try. Okay. Uh, Anna Maria says, is the long COVID a coagulation problem, microthrombi, due to antibody that for some persons attack the blood vessel tissues? Long COVID, we have done this discussion multiple times in the past. One possibility of the post-COVID persistence of symptoms is that tissue damage was such that those tissues are not healed yet. And so the person is going in sequelae, and tissues would slowly repair, for example, lungs or throat and nose and any other tissue that may be involved. It is also possible, depending upon the severity of infection and tissue damage, that some tissues may not recover fully. For example, we have talked about those people who are hospitalized, for example, and maybe even on ventilators. They might develop baby lung pathology or physiology in which the lungs are damaged and scarred and shrunk, and such folks may not be able to sustain their normal routines without oxygen um, availability forever. Plus, they may have to do rehabilitation to improve as much as they can. So that is one possibility, tissue damage and the effects of the damage. Then we've talked about it, that it is also possible that the mast cell activation occurs, or macrophage activation syndrome occurs, or immune system dysregulation occurs. There could be multiple pathways, including the monocyte, which is patrolling the boundary. This is Dr. Bruce Patterson's theory or paper. Monocyte patrolling the blood vessel boundary, causing inflammation of the blood vessels, which may in turn cause not only thrombi but congestion in the system as well. So, going back to your question, and I want to make sure that we are clear on this, a vaccine does not cause long COVID, because COVID is with SARS-CoV-2. Vaccine is not SARS-CoV-2. So vaccines cannot cause long COVID, but vaccine could have their own side effects that might continue. And because the part of the vaccine, spike protein, and the part of the virus, spike protein, are very similar, many of the side effects can be similar in the long run. So that is an important distinction to keep in mind. Now back here, is the long COVID a coagulation problem? It is possible. We talked about one more concept of long COVID. That was a study that said that blood cells morphology changes, the cell structures can become bad. And hopefully, by the time those cells are replaced, we continue to make our blood cells again and again. And so, as they would be replaced, the person would start feeling better and better. Microthrombi may be occurring as well. So, can the blood vascular tissue can there be antibodies? So far, I want to also discuss this. This may not be a long haul thing. The clotting issue is because of the antibodies attacking platelet factor 4. That is the research from German scientists. Platelet factor 4 is attacked by the antibodies, which cause platelet activation. That causes platelet coagulation, or not coagulation, platelet kind of aggregating together, causing clotting. So that can give rise to microthrombi. Now, vascular surface damage may be occurring because of the monocyte carrying S1, or may not be. We're not, I mean, there is one study with Dr. Bruce Patterson, and he's managing patients around that as well. But there are more studies and more research needed. So I hope that answers that question. Good question. How are things here? Uh, let's see. Okay, so I don't see a question here in the live chat, so I'm going to go back here. Okay, so next question. Bill Berna says, Dr. Bean, can you please comment on the JAMA network analysis of the effectiveness of the adenovirus? So I actually went to that study. Let's open that up. I think this is that study. So this study is interesting. So again, within the question answers, I can just very quickly talk about it. I don't know if it is needed to talk as an independent one lecture. Here is what they're saying. What they're saying is they're talking about Janssen, and they're talking about efficacy of Janssen. And what they're saying is this comparative effectiveness research study found that through large-scale longitudinal retrospective curation of electronic health records. It's a large-scale retrospective. So you go to the computer, you pull people's record, and then you see this. And from multi-state Mayo Clinic health system, the adenovirus vaccine, or the Johnson & Johnson Janssen vaccine, had an effectiveness of 74%. And if you see here the data, the study was composed of 8,889 vaccinated patients, and then 88,898 unvaccinated patients. The incidence ratio of SARS-CoV-2 infection in the vaccinated versus unvaccinated control was 0.26. And confidence interval is correct as well. It's not crossing the unity. So 60 patients out of 8,889 vaccinated became infected versus 2,236 out of 88,898. That gave an efficacy of 73.6%. So good efficacy, not bad. Although I am really not a fan of Johnson's vaccine. My wife had it and she continues to have side effects. Women under 50, I still feel the same from the studies. And now a person in my own home, women under 50, adenovirus-based vaccines are, so this was Luffy. Okay, continuing. We took this single shot vaccine in August and are trying to get a sense of its real world effectiveness before deciding about boosters. Thank you. So they have said that for adenovirus based vaccines, booster, and Johnson & Johnson in the US, Janssen, booster after 2 months, you are eligible because the efficacy is this is Luffy. How are you, Luffy? Because the efficacy drops because it is a single dose vaccine. So the recommendation is to take the booster after 2 months. Hey, Luffy, how are you? Are you here to sleep or sit down? Okay, so Luffy is here to disrupt us. You want to see Luffy? He just walked away. He just went to the other camera. Do you see him? Do you see his little ears? Now who's going to save us from Luffy roaming around on this table? Okay. Back here. The EA. Share the news. This is very good news. Covaxin has been recognized and approved by WHO finally. So I would have said recognized and authorized for emergency use. So let's look at that. That's a good news. Here, Covaxin, I was trying to find it. I think this is it. This is BBC's BBC's news. So if you see here, BBC says this is 3rd November. Today is, of course, 10th. WHO approves India COVID vaccine for emergency use. So emergency use authorization is given to Covaxin, which is excellent. So here, Bharat Biotech, which makes the vaccine, has since published data suggesting 78% efficacy. So that is a good news. Continuing with the discussion, EA, thank you very much. I'm going to see if there are some questions here on this side, on the live side. Luffy, what are you doing? You know that we are all sitting here doing some serious talks and stuff, right? Okay. No. Luffy wants to sit down actually in my lap. Okay, so Jovi Javi Cortez says, I had a stroke after my second Pfizer shot. My potassium levels were really low in the ICU, historically normal. Is there anything that might link the two? Do you know of any groups for resourcing information? Stay cool. Very sorry to hear that. I hope that you are doing better. Please tell us more about your recovery. There are many Facebook groups where these discussions are. Unfortunately, there are so many of such groups that are just stopped by these folks thinking that somehow talking about vaccine related injury means being anti-vaccine. Just not good, not cool. And the potassium levels low, I cannot connect it to the vaccine itself. Historically normal. So no, I can't say what is the relationship of the Pfizer shot and potassium. But stay cool. You too. Tell us more if you would like to. If not, then totally it is your private information. And I hope that you fully recover, or you have fully recovered. I hope and I pray. More questions. Let's see. So, Colin, this is very interesting question. Why don't they just up the dose and vax now? They need boosters. So, in my opinion, the way, so you can tell I'm not a big fan of this. My wife had it, and I'm not very pleased with this vaccine. However, I think instead of upping the dose, it may be interesting to declare Johnson and Johnson vaccine as a two-dose vaccine as well, instead of saying one dose and now take a booster. So Jeff Wright is saying, are there any vaccines now available in the US? No. Or perhaps coming, I read the whole question before, or perhaps coming soon to the US that don't use the complete spike protein or cause its expression as in the mRNA vaccine. Let's see if other vaccines would arrive, but so far nothing else is approved. There are many vaccines, there are many technologies that are available but not approved. I mean, look, we are waiting for Novavax. It has a full spike protein on it, but that full spike protein is also stuck in the form of a particle. So hopefully those spike proteins cannot just run around. But Novavax's statement is that they will be able to apply for the emergency use authorization by the end of December, by the end of this year. So there is at least about 40 more days for us to wait. Other vaccines, no. And I don't feel that other vaccines have a chance. They're trying because US is a very important market, but US already has enough vaccine. I think they don't have enough people now saying that I want to have a vaccine. That is a problem instead of having the vaccine itself. And really, if there is anyone who's not vaccinated and you don't have a reason for that, meaning you don't have a medical condition or others, then protect yourself. This is important. Okay, so Evitar says, talk about Medicago plant-based vaccine. That's a good one. It's from Canada, and I think I had a discussion like this, but not a separate full talk. Nipa is here. How do you consider Novavax as a booster? That would be a nice one as well. Novavax as a booster. That would be a cool one too. Petizik says, can you get Kyrie on camera? Still would love to see her. Kyrie is very difficult to get on camera because she does not like us to hold her. So she is the independent queen of the house. I would see if we can. She does come around by her own choice and just roam around and go. I'll see if I can grab her. It's a little more involved to get Kyrie. To get Kyrie, I have to ask my wife to go find her and catch her and catch her and bring her over. Okay, so continuing. John Snyder. John Snyder is here as well, or was here at least. John Snyder, 2006. NSP8 and NSP9 crossing the blood-brain barrier due to interleukin-7 and T-cell responses. Then GLU-N1 and GLU-N2 of NMDA are similar, similar structurally to NSP8 and 9. So what John is talking about is that in our brain, there are um, chemical substance and their receptors that help function our brain. There are many kind of chemical substances in the brain, and virus protein, non-structural proteins could, he's saying. And John, I do not have the paper, but because you've been uh, studying and sharing so many papers on Discord, I'm hoping that this is coming from a paper. So if NSP 8 and 9, we take it on the face value from your question that it does cross the blood-brain barrier, then yes, it can cause an NMDAR encephalitis if the structure is the same. So then your question is, how would this be expressed symptoms-wise in the patient? So let's very quickly look at it. Here. So anti-NMDA receptor encephalitis. So again, at the end of the day, this is encephalitis, which would mean congestion and swelling of the brain tissue, inflammation of the brain tissue. And the answer is symptoms are going to be the same as other encephalitis as well. So if you see here, seizures, decreased breathing, blood pressure, and heart rate variability because there's compression going on. And then if you see here, signs and symptoms, prior to the development symptom complex, receptor encephalitis, people may experience prodromal symptoms like headache, flu-like illness, and so on. So that these are here. And then you've asked that how do we diagnose it? So here are the diagnosis. MRI can be done to see the congestion and the edema in the brain. EEG, brain electroencephalograph can be done. Lumbar puncture and CSF can be seen, and so on. So there are a bunch of tests that can be done. Good question. Okay, so do you think Indonesia will capture side effects of Novavax that occur in world's first rollout? I don't know. I wish they do. I am, for example, from ever I had been not very happy that US is not capturing and presenting the data as we would love to, like Britain or Israel was doing. Now the CDC has started reporting some data, and there is some decent data available. We trust them or we don't trust them, but there is data. So I hope Indonesia would do it. I think it would serve Novavax better if Novavax made sure, just like Pfizer made sure with Israel, that hey, we'll give you the vaccine on priority if you give us the data. So if Novavax did something like that with Indonesia, it would be awesome. Matthew Trujillo says, "What kind?" Sorry for not pronouncing the name correctly. What kind of a cat food? What kind of cat food brand does Luffy eat? So Luffy primarily eats two kinds of foods. One is the salmon or wet food, and he eats salmon with gravy or without gravy. So I think Eplos is salmon, and I believe it is blue buffalo salmon, if I'm if I'm saying the brands correctly. And then he also takes dry food as well, which is also salmon based dry food. It's all about salmon. And he has a sensitive stomach, so we used to give him chicken based foods, and that did not work very well for him. So he takes mainly fish based food. So Snowman Mike says, this is one more question, and then I'm going to come over to the other side. I thought today we would just be done with all the YouTube questions, and we're still almost in the middle. Do you think anything will happen in 5 years from now because of possible side effects? So of course I cannot actually know what would happen. I cannot even know what would happen tomorrow. But um, there are some things that are possible. For example, if people have developed pancreatitis as part of COVID infection, then it is possible some of them will become diabetic within next few years. So imagine me, I'm now above 50. So my pancreas should have lesser islets anyways. Infect that pancreas with SARS-CoV-2 or attack that pancreas with some antibodies. And now more islets are destroyed. So if I was going to become diabetic, let's say 10 years later, I might become diabetic 4 years later, 2 years later, 5 years later. So that is one possibility. Another possibility is, let's say, lung damage. And if that lung damage persists, then oxygen requirement in those, can they continue or not? I think you have a specific thing in your mind, and that may be that will the uh, DNA changes or messenger RNA integrations, or are cells having genes of this vaccine, or there are so many kind of rumors out there, will they, or let's say that spike protein based study that we talked about, which says that there may be DNA change, and somebody had put a comment that cancers can appear 4 years 5 years later. So for a cell that is cancerous, it is possible there are some cancers that very slowly develop and can take many months. But for a cancer to stay under the radar, meaning do not become big enough and do not create a mass that can be seen, or that would have this pressure effect, or that would cause inflammatory reactions and so on, for that to kind of lay low for 5 years and then appear is not going to be a very easy thing, at least as far as I can tell. There are cancers that sometimes we do not find because they are in the hollow viscera, for example, let's say uterus, and may not be detected more easily earlier on because the pressure effect may not be seen, and so on. So there could be cancers that lay low for longer. I don't know if there are such cases. So I think that would not be a big risk, but I have not seen what would happen in the future. Again, as I said, I'm going to wrap it up my answer with the same. I do not know what would happen tomorrow. So let's look at this side. Denise says UK cancelled its Novavax contract. Why? That's an interesting news. Why? That is an interesting news. Um, can we actually find that news? UK cancels Novavax contract. Interesting. So, Valneva shares crater as UK cancels order for 100 million COVID-19 shots. This is September 13. Shares in France's vaccine specialist Valneva SA were sharply down after the UK government tore up a contract to supply 100 million doses of its COVID-19 vaccine, codenamed VLA 2001. Until today, Valneva was one of the largest COVID-19 vaccine contractors with the UK government, which got its order early in the pandemic. Valneva was supposed to be supplying 100 million doses. The same thing they wrote about 4 times. Is this Valneva Novavax 104 approved travel jabs? Is Valneva Novavax? Or am I looking at something else? Valneva. I want to make sure. Commission approves contract with Valneva. Looks like they're the same one. What is this? So this says coronavirus. Commission approves contract with Valneva to secure a new potential vaccine. So this is the news from 10 November. So today, 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 the European Commission approved the eighth contract with a pharmaceutical company with a view to purchasing its potential vaccine against COVID-19. So interesting. The contract with Valneva comes in addition to other. So looks like Valneva is different because here it says Novavax. So Valneva may be something else. UK cancels Valneva in September. Did UK cancel Novavax? So sorry that I do not know the difference between these two. UK. Okay, so I don't want to waste your time. If Valneva and they don't seem to be the same. So it looks like UK cancelled Valneva. UK to offer licensed COVID-19 jabs to Novavax. Can you please? UK to offer licensed. Please stop this. I hate this cookie setting is just such a noise. UK to offer licensed COVID-19 jabs to Novavax Valneva trial participants. Are they the same thing? Okay, so from Monday, investigators will begin inviting more than 15,000 Novavax trial participants in England to come forward to discuss whether they would like to receive two doses of BioNTech Pfizer 8 week apart. Department. The scheme will then be rolled out to those who received Valneva's vaccine candidate. In total, 21,000 volunteers have been given a vaccine not yet authorized by the Medicine and Health. Okay, so there is something going on there. Valneva is cancelled, 100 million doses. Okay. Paul. So Dr. Chetty speaks of Joe and says, Dr. Chetty speaks of addressing the eighth day of COVID infection. Is that eighth day from symptom or eighth day from estimated day of infection? I think he says eighth day of symptom. That's what my understanding is. Paul Bork says, if we don't know how the baby generated, so we talked about this a day earlier. Sweetheart says, what can we do to prepare for the first vaccine? Does taking the flu shot with COVID actually lessen severe reaction to the COVID vaccine? Thank you. So there are many ways that you can approach the vaccine. I don't want to specifically talk here, but there are protocols because that would become a personal advice. I don't want to give a personal advice. However, this has been the practice that if you're going to take one vaccine of one type, usually the doctors say, and I recommend the same thing, to separate them out so that if there are side effects occurring, we can tell which vaccine it is causing, which vaccine is it that is causing it, and then we can take appropriate actions to get ahead of it. So my opinion, SARS-CoV-2 vaccine should be taken as isolated from other vaccines as possible. Okay, how are things here on this side? Gift 24 says I need Luffy's advice. So Luffy, I'll show you now where Luffy is. So sorry for this jarring camera switches, but guess where Luffy is? Luffy is sleeping on his chair, you see? So he has a permanent place next to me. And so he sleeps there. No, not under the desk. So let me show you once more. A quick break in the studies. So here is the desk, right? If I stop sharing for a second. So this is the desk. Sorry about all this lighting. This painting, this one, this is a watercolor painting that I did about 5 years ago. And this was inspired by another painting. So Luffy is over here. So if I pick up this and here, so this is my desk. and Luffy is there. So here we are. Luffy is funny. Bambi Secret says, nice painting. Thank you very much. Okay, so, wow, that is a very interesting comment. Sean says, I have 3 cats and I'm taking care of 6 more outside and 4 of them come in. So I'm always covered or cornered by cats. Yeah, so we have 2, and one is Luffy is very demanding and very dog-like cat. He's always there. Kyrie is very isolated and she just likes to be on her own. All right, so continuing with the discussion, I want to make sure that I can get through the YouTube side today. So, sweetheart, I hope that helps. Rob, what is the reason that there is, as far as I am informed, no level of antibody or range of antibody levels defined yet that tells a person is protected? We have had this discussion many, many times. I don't think we are at a place yet to be able to say, here is the standard international level BAU that is the protection level. So now an interesting attached question is, then how do various studies assume that what level is protective from vaccine or from infection? So I think they have arbitrary numbers. For example, BAU of 11 is thought to be protective. Above 11 and 11 is thought to be protective. So that's an arbitrary number. So we still do not have a good number. Then, if you have a long question, 2, as one knows that the antibody levels IgA and IgG drop after a certain amount of time, why do we test them as gold standard and not the T and B cells? Because that's what we have been doing incorrectly. Maybe it is easy to do because just take these samples. Maybe testing B and T cells, we have to do the binding, although you know that now T detect cell test is approved. So you are correct. If testing the T and B cells is too expensive, why is there no interest to invest the money to develop a test that is less expensive? So these are all actually good questions. And we have actually spent a lot of money on other therapies. We have lost a lot of money. People are going bankrupt in this whole thing. So yes, your questions are on point. Are there studies, number 3 part of your question, or third question? So in the future, I would answer one question at one time. Are there studies that compare the amount of hospitalized, reinfected, and breakthroughs? If yes, what is the ratio and who are they? Age group, comorbidities levels. So vitamin D is one important thing, Rob, that I don't know if we have correlates of those. Although vitamin D studies separately are coming in, but this stratified data of breakthroughs, hospitalizations, death with these variables, I don't think are there. So these are good questions. Okay, so Carolyn DeCane says, does administering boosters periodically have the potential to reduce transmission from vaccinated people? So again, there is a basic, similar question as above. There is a basic assumption that is being used as a fact here, and that is that vaccinated people transmit. So if now I'm going to respond with the possibility of transmission. If we're talking about a person who's vaccinated, gets infected or exposure, breakthrough occurs, he then sheds and he doesn't know or she doesn't know that they have the infection, or maybe they just develop mild symptoms. I think it's just common cold. In such cases, if your question then becomes that if they had a booster and the immune system was active and IgA was present, then will this person transmit as much? The answer is no. Because if the cells are active, IgA is present in the mucus. Then when the virus would come in, it would get trapped and attacked. So the virus load increase is not going to be easy, and then shedding would not be easy. Even if the virus is going to be shed, it would have those IgA pieces attached to it, and that would be kind of a not viable virus. So that's a good question if it is put in this context. Rima says, please help explain Delta and Delta plus symptoms in vaccinated. They are different than previous variants, and people, even docs, aren't recognizing them fast enough. I think, and again, I'm not super up with the Delta plus symptoms because US has been less, but Delta plus more toward gastrointestinal system. So if I go here, although this is a page from Egypt, look, I've been doing homework. Where is that page? This was somebody who was interested in co-vaccine. This is my video of co-vaccine in the past. UK effect. Apologies for doing this. Here. So this is Egypt today. And just I wanted to have these somewhere in one place. And so here we are. Delta variant is still the dominant strain of corona. The virus is very active, experts suggest, and we know the symptoms. I think one additional symptom was runny nose. And so Delta type symptoms include respiratory difficulties, GIT complaints, and then other. So here is Delta plus. Lung infection is quicker and faster. Shortness of and difficulty of breath is faster. Long-term fever and persistent cough. The cough is important. Persistent cough. GIT symptoms is also important. Skin rashes is also important. Dry, watery eyes, loss of appetite, and nausea. Now, dry and watery eyes had been with the original viruses as well. Loss of appetite and nausea is just associated with GIT as well. However, more GIT symptoms, faster lung, impact, and persistent cough and fever are interesting. So that's a good question, Rima. Thank you. So we are almost at the end. So if I can continue going here, I hope you will be okay. So let's do this. Lisu says, which is the most reliable online database to study adverse effects of a medicine, drug, and vaccine? I think easiest is to go to drugs.com. There are many paid versions as well, but if you start with drugs.com, then you can further see if that doesn't serve your purpose, then there are more. Stephen Kame Lindenblatt says, why do you think Novavax will be available for children? So they are going to apply for EUA in December or by the end of this year in the US. What I don't know is if they're going to make it available for children yet. I think it would be late, just like others are late. Be Prepared says, my two teenagers have had COVID and then just in August, they had HFMD. So hand, foot, mouth disease. They both have fingernails that look like they split or fell off, and now only a bottom layer of nail covers bottom half of fingernail, the nail bed, and top half with oldest growth looks twice as thick compared to it. Sometimes when the nail bed becomes infected and damaged, then it doesn't make the nail correctly. Usually it becomes okay with time. Sometimes it does not. Can you discuss, please, post-COVID fingernails versus post-HFMD? Yes, I would take it up. So let me just write it down somewhere. Taking notes. Post-COVID fingernails versus post. Okay, got it, wrote it. Continuing. Bryo last says, no medical question for a doctor. Arubaga says, what Indian food supplements can reduce inflammation? I only know of turmeric, spice powder, and kalwanji seeds. So kalwanji and turmeric are the ones that I am aware of, but I'm sure that there are many. So turmeric, curcumin. So within my home, turmeric, curcumin, kalwanji, and fish oils are something that we use very often. Okay, so then Griffin Lawrence says, I don't know if the research info has been released, but have you looked at the COVAX 19 vaccine created by Vaccine yet? If you have, what are your thoughts on it? So I had not, but for this discussion today, I just looked at it. This is vaccine Synogen. This is COVAX 19 or Spicogen. So it is interesting. They have done phase one trial, then they are doing their phase two trial in UK. They were, then they did phase three, and they are approved in. I said UK. They are approved in Iran. So that is very interesting. It is a protein subunit vaccine. What I did not find was the site's own, um, information area. So I read from the clinical trial that this is a subunit like Novavax. It is a spike antigen with an adjuvant, but I do not know how exactly they have structured it. The trial is using this spike protein in the people who would get the vaccine, and the others are getting saline. But exactly how the vaccine itself, the technology, how is it built, I just could not find any link to find it. Otherwise, I would have created those little diagrams to show. The EA says, is there any evidence showing how and if COVID affects people who have no comorbidities but had previous comorbidities? And you give various examples like obesity or hypertension. So no, there is no study I have seen so far, but it's an interesting question. I would assume, so this is my assumption, I could be wrong. My assumption is that somebody who was obese and not, generally they should be fine. They should be treated as not obese. Similarly, if somebody had hypertension and not have hypertension anymore, and or even if they're using medicines to control it, they should be treated as healthy for uh, COVID. Again, these are my assumptions as a doctor. Maybe I'm wrong in this one. And same is the case for other as well. So that's a very good question. I'll see if there are any studies. And with this, congratulations to all of us. The YouTube side is done. We will continue with the Twitter in another day. So now my question to you, tomorrow and day after, as I have said, somebody on Twitter did something, we can't put COVID videos on the site. So I have to add more videos, some teaching for the folks on the site. So I wanted to do non-COVID talks couple of days a week. Are you comfortable if tomorrow and day after I take up some other topics that would be valuable for folks on the site as well, and that we can use here as well? I was thinking of in microbiology, I was before COVID, I was doing microbiology. And the next lecture that has been waiting for 20 months is Bacillus anthracis. So if you are comfortable, we would do Bacillus anthracis tomorrow, and then day after we can decide some clinical lecture. So with this, thank you very much for being here today. Let me just scan the comment side and see if there is any question here. Otherwise, we can break for today. So Tool Fogger says, thanks, Dr. Bean. That was totally honest. You're very welcome. I forgot. So Echoist says, yes, vaccine concern is with Moderna and heart enlargement studies in USA with men in particular question. So I have done that discussion just yesterday. So if you can look at or watch that video, please. It is men have more incidents, and then young men, I think between 24, 18, they have more. 18 is the age with the highest incidence. Rare, somebody had sarcastically said rare question mark. Rare, I mean, out of millions and millions of doses, lesser. And then they recover as well. There was another unfortunate um, thing that somebody, a mother had said that, hey, my son is in ER with that, or was in ER with that. And of course, she was distressed, and I understand that. And so sorry for that. So the men, younger men, are more prone or have a greater incidence. Fortunately, at least in the US, there has been no death. According to the American Heart Association's article I discussed yesterday, there are no deaths reported. So it's not exactly heart's enlargement. We use technically heart enlargement as a permanent enlargement because of the cardiac muscle, hypertrophy after, let's say, continuous, chronic, uncontrolled hypertension, etc. This is more of a inflammation. So swelling, you can call it enlargement, but technically, medically not. Swelling would be more accurate. So inflammation of the cardiac tissue or pericardial, cardiac muscle or pericardial tissue. That is the pathology. So with this, thank you everyone to be here. Thank you for hanging out with this discussion and hanging out with Luffy as well. I would see you tomorrow. Tell me, I'm going to leave you with this question. Is it okay if I did Bacillus anthracis that causes anthrax tomorrow? That would give me a lecture that can be put on our site as well. And with this, if you would like to support this work, there are some links in the description. You can buy me a coffee, or you can use Patreon, or you can use PayPal. Thank you very much. The least if you can do is like this video, subscribe and share if possible too. And that liking the video would help as well. Thank you. I'll see you tomorrow.